So the next item on the program is the national update, just to give you a brief review of our activities over the past year. So as you know, the VQI is a clinical registry primarily focused on vascular care. And as I think the great majority of you are aware, the mission of the VQI is to improve the quality, safety, effectiveness, and cost of vascular health care by collecting and exchanging information. In summary, we're improving care through a data-driven approach. We have 18 clinical registries on vascular care. We're organized under the auspices of a patient safety organization. This has certain advantages, as our patient safety work product is immune from discovery in the legal process, and hopefully it provides an opportunity for people to freely enter their data and their outcomes without concern about repercussions from it. We have 17 procedural registries on open and endovascular care and one disease-based registry. We collect demographic, clinical, procedural, and outcomes at the index hospitalization and one-year follow-up. We also can obtain longer follow-up using Medicare claims linkage that allows us to get indefinite long-term follow-up on these patients as long as they have a billable event within the Medicare system. And we can also follow long-term survival using the Social Security death index. We now have over 1,200,000 patients in the registries, adding over 10,000 cases a month. As you can see, the PVI registry has over 400,000 cases, carotid endarterectomy 200,000, and most of the registries have at least 20,000 procedures in them. So it's really a robust source of data for analysis and really has provided a lot of valuable information. We've now had over 800 peer-reviewed publications that have significantly affected practice, and in many ways they've changed the way we practice, for instance, with regards to carotid patching or reversal of heparin with protamine after a carotid operation. No doubt these changes in practice, such as things like as simple as discharge medications, has significantly improved survival and contributed to the saving of thousands of lives over time. It is a little disappointing to see that our Vascular Medicine Consult registry has not taken off. I think that's something that I hope you will all consider. Almost all the registries you hear about, the trauma registry, the transplant registry, cardiac registries, are all procedural based. But this disease-based registry looking at carotid stenosis, aneurysm, and lower extremity occlusive disease that is treated medically really allows us an opportunity to look at the natural history of care and to look at the impact of medical management, smoking cessation, exercise programs, and so on. And so, you know, it's a unique opportunity for us to better understand what patients need in operation, and maybe more importantly, what patients don't need in operation. We spend a lot of time telling our patients, trying to get them to quit smoking or to exercise, and this will really allow us to determine the impact of that. There's a lot of concern within hospital budgets about paying for another registry. There's a certain amount of registry fatigue, but I think this is really a valuable registry, and so think about getting your centers to sign up for that so we can really learn what's going on with medical management. One of the concerns about VQI is that it's a voluntary registry. Our market share is somewhere in the 25 to 30% of all of the vascular procedures that are done, at least in the US. And so it gives a good handle on it. And here you can see the comparison of the VQI patients, and that's a mislabel, it's not NIS, it should be a Medicare, comparison to Medicare. And you can see that our proportion of white patients, black patients, is very close to what you're seeing. So it really is a real-world sample on these patients. We have a good variety of hospital types. It's not just large academic medical centers. About 1/3 of our participants are academic centers, but about 30% identify them as teaching affiliate or teaching community hospitals, and almost 40% are community hospitals, office-based laboratories, vein centers. So it really provides a good reflection of the variety of different sites and locations where vascular care is being delivered. Even though the registry is sponsored, the VQI is sponsored by the Society for Vascular Surgery, less than 1/2 of our physicians identify themselves as vascular surgeons. We have strong representation from interventional cardiology, interventional radiology, general surgery, cardiac surgery, neurosurgery, and others. So again, it's a reflection of the total vascular care within the U.S. and really provides real-world evidence. One of the unique aspects of our registry is the biannual regional meetings where we get together to discuss outcomes, to talk about quality improvement projects. And most of us spend our time within the walls of our own hospital talking to our own colleagues, and it's rare we get an opportunity to learn how people are doing things across town or across state lines. And I certainly have learned a lot at my own regional meetings about how care is delivered elsewhere and how we do things differently. So I think it's a unique opportunity. We're still working on, what model we should be using, whether it's required live in-person meetings or hybrid meetings. Certainly the advantage of a hybrid is it's easier to attend and it takes less of your day. But you lose that networking and hallway conversations where a lot of important stuff really gets discussed. Although we're sponsored by the SVS, we are very proud of our strong collaborative relationships with other societies. As you probably remember, we merged our PVI database with the American College of Cardiology, NCDR, a couple of years ago. That's been a very successful collaboration. We have cardiologists and radiologists serving on our executive council and many of our registry committees. We also work with the Society for Vascular Medicine, American Venous Forum, Society for Vascular Ultrasound, American Heart Association, and the Vascular Access Society of America. Again, I would like to thank our supporting industry partners, BD, Gore, Janssen, Silk Road Medical. Their financial support really allows us to start new programs, to do revisions, and to really upgrade our product, which we wouldn't be able to do without their support. One of the other unique aspects within our registries is the capture of the global unique device identifier. And as our mission of patient safety and improving vascular care, we have to determine what products work and what products don't work. Our device has been used by FDA for device evaluation. It's been used for label expansion and has been contributed to some of the panel discussions on COVID and also on EVAR devices and the failure of EVAR devices. While we have integrated GoodID into some of our registries, GoodID does have some issues with missing data, incomplete data, and so we have partnered with Symmetric Health Solutions almost 2 years ago, and they have an algorithm to help fill in and correct some of this missing data. What happens is that the original GoodID may be filled out, and then the company gets bought. And so now they have a different name or a different model number. And in some place, there's incomplete information on GoodID. So in our partnership with Symmetric, it really has upgraded the device data that is included, making it more complete and more accurate. And we have 180 additional device attributes that are now captured, a significant increase from the GoodID data. And the feedback we get from our members is that the resulting data has made the data abstraction more efficient. The device assist allows you to use the model number, the manufacturer number, the product number, or the barcode scanner, which we found out almost nobody is using. But we'll take a look at that. As part of our mission for improving quality, we have developed a couple of national quality initiatives. A couple of years ago, we started one on discharge medications. A study a few years ago showed that just by discharging the patients on appropriate medication, antiplatelet agent and statin, would significantly reduce mortality over a 5-year period of time. And so we've had that as a national quality initiative, and many of you have used that as a quality charter at your own institution. We also had a national quality initiative on EVAR surveillance at 1 year, and many of you have also used that. Last year, we decided to add one more national quality initiative, and this effort was spearheaded by Gary Lemon, and it was decided to focus on smoking cessation. This is for any of you who have dealt with patients and tried to get them to quit smoking, this is a tough one. Because it's mostly related to arterial disease, it was only focused on the arterial registries. We began the reporting measures in the spring of 2023, only for elective procedures. Didn't think it was fair to have smoking cessation prior to an emergent operation, not enough time to do so. And then we looked, in addition to looking at pre-op smoking status on elective procedures, we looked at smoking cessation following all procedures. We had a couple of additional variables in August of last year, and it will start to be included in the participation awards next year. There were a number of smoking cessation resources that were added to help centers comply with this. There are patient-facing resources, physician resources in terms of billable codes and tip sheets. There are toolkits. There's a collaboration with the SVS Education on the SVS website, podcasts, charters, and webinars focused on smoking cessation, along with mentoring and networking events. And there is also now a certified tobacco treatment specialist, which many centers have incorporated into their own workflow. In terms of the smoking cessation resources, this is a billable code. This was provided by Dr. Char from Yale, providing language that could be used in the chart so that you would qualify for the CPT code for smoking cessation billing. And there's a separate resource for Canadian patients listed there, and below you can see the website that can be used. So we did a survey on the certified tobacco treatment specialist and found that of 110 centers, about 45 of them did have a certified tobacco treatment specialist, and 43 did not, and 22 weren't sure. And oh, I'm sorry. The first question was related to a smoking cessation program. Do you have a program at your center? About half did, a few were unsure. And then the second questionnaire is related to whether you had a certified tobacco treatment specialist at your center. And most did not. A large number, almost over half didn't, and a large number weren't sure if they did or not. So something that may be worth looking into. Next, we'll move on to our fellowship and training program. As you heard earlier, this is now being chaired by Adam Johnson, who was previously introduced to you. And I will also, along with Adam, I will call up Dr. Lemon and Dr. Cronowet to the podium. And the scholarship program is named in honor of Dr. Jack Cronowet, and I would just like to introduce him to you briefly. He's a professor of surgery emeritus at Dartmouth-Hitchcock Medical Center and the former chief of the section of vascular surgery. He was really the founder of the vascular study group of Northern New England, which morphed into the vascular study group of New England and eventually into the vascular quality initiative. In addition, he served as the medical director of M2S, which became MedStreaming, which became FIVOS. He is a past president of the New England Society for Vascular Surgery, Association of Program Directors in Vascular Surgery, and the Society for Vascular Surgery. He's editor emeritus of the Journal of Vascular Surgery and a previous editor of Rutherford's Vascular Surgery textbook. He has received the Lifetime Achievement Award from the Society for Vascular Surgery and also from the Association of Program Directors. I would also name his other honors and awards, but we don't have the time for it. And so I will now turn the podium over to Dr. Johnson, who will tell us about the Fellowship and Training Program.
Yeah, so thank you very much for the time to highlight this program a bit more. In Dr. Kronowit's, honor, we've named this scholarship to really support these budding leaders who maybe someday will have the accolades that he carries. And the goal here is to highlight these trainees who have wonderful projects, to provide them some additional administrative support with one-on-one meetings, with involvement in committees, to provide them funding to attend meetings, their regional meetings or these national meetings, and attend strategic board meetings, statistical support to analyze these projects and connect with the PSO executives, and then to cross-train, give them exposure across not only their institution but other institutions. And so we are really excited to announce our next class of the VQI Fit Scholars, and I'll turn it over to Dr. Kronowit.
Thanks, Adam. Thanks, Jens. Good afternoon, everyone. Just a couple of comments before I introduce this year's Scholarship Award winners. As you know, I've been coming to this meeting for a number of years, and every year I come, I'm more impressed by the breadth and the quality. And this year I would also add the engagement of the audience and the excitement and enthusiasm around quality. I think, Jens, you'd agree that when we started VSG&E, this wasn't even a glimmer in our imagination. It's just spectacular to see. And focusing on our scholars, as you know, this is a competitive award. All of the participants in the first year program can apply. Unfortunately, only 5 can be selected, and I say unfortunately because they were really all worthy of the scholarship to support their future endeavors in the quality initiative. And I think you'll agree with me, and I'm going to briefly describe what they've done. What an impressive group this is. There's certainly, I can't imagine anything that I would rather be associated with than this particular scholarship program. So I'm going to tell you a little bit about them, and we're going to ask them to come up along with their mentor to receive an award that the PSO has prepared for them. So here we go. Our first awardee is Dr. Saranya Sudarmaham, who is a third-year integrated vascular surgery resident. And I think we have slides for those. There we go. Okay. A third-year resident mentored by Dr. Tom Brothers at the Medical University of South Carolina. Dr. Sundaram spent this past year doing a quality improvement project after identifying longer than expected length of stay after carotid treatment, either endarterectomy or stenting at MUSC. By using VQI data, she identified contributing factors that could be improved and then created a multi-specialty program to standardize perioperative medication, adjust hemodynamic parameters, and support early rehabilitation. Next, she will monitor the outcomes of this program and adjust or add to it as needed to reduce the length of stay after carotid treatment. Unfortunately, both Dr. Sundaram and Dr. Brothers are oh, she's here. Oh, okay, the plane has landed. Please come forward. Thank you. Our next awardee is Dr. Michaela Lowenkamp, who is a fourth-year integrated vascular surgery resident mentored by Dr. Michael Madigan at the University of Pittsburgh Medical Center. Dr. Lowenkamp did a quality improvement project after identifying a deficit in aspirin and statin prescription, as well as increased smoking rates after vascular procedures at Pitt. She developed a vascular-specific discharge note, including recommended medications. She initiated provider education about best practice and created an internal mechanism to refer to the institution's smoking cessation program. Oh, thank you. Going forward, she plans to strengthen and monitor this program and to measure its effectiveness. And again, unfortunately, I don't believe Dr. Lowenkamp was able to make it, but we do have Dr. Madigan here, her mentor, to accept the award on his behalf, on her behalf. And I'll just mention that, as has been said earlier, that not only are the scholars they've done the work, but the mentors of these scholars and the specifics around the program that has been developed with shadowing different people in VQI has really been critical. So the mentors are certainly important and to be recognized. Thanks. Our next awardee is Dr. Mitt Curry, who is a senior vascular fellow mentored by Dr. Nick Zacharias at Massachusetts General Hospital. Dr. Curry did a research project to evaluate the outcome of patients who are deemed unfit for open AAA repair. While most such patients underwent EVAR with better initial outcome than those undergoing open repair, this benefit was lost after 1 year. Further, it did not appear that there was a consistent definition of unfit for open repair across the institution or across VQI. Dr. Curry prepared this research for publication and plans going forward to delineate more details to better define and then manage patients who are unfit for open AAA repair. Thank you. Thank you. Our next awardee is Dr. Chris. I'll get this by the last one. Our next awardee is Dr. Christopher Chow, who is a second-year integrated vascular surgery resident mentored by Dr. Arash Bornak at the University of Miami Medical Center. Dr. Chow performed research to examine the incidence of cerebral hyperperfusion associated with carotid stenting in VQI. Specifically, he compared and found differences in this complication when comparing TCAR versus transfemoral stenting, which he is presenting at a poster at this year's VAM meeting. He plans to continue to explore other potential factors associated with cerebral hyperperfusion and in the specific patients in which it occurs to develop potential methods to reduce this complication rate going forward. Dr. Chow? Or Dr. Bornak? Okay, well, we'll make sure that they get this award. It's great work by them. Okay, and our final awardee is Dr. Amanda Filberto, who is a senior vascular fellow mentored by Dr. Adam Beck at the University of Alabama at Birmingham. Dr. Filberto became interested in potentially better methods to assess postoperative renal dysfunction in VQI. She found that the current mechanisms are not very sensitive and then investigated new measures that has been proposed by the International KDIGO practice guidelines, which are likely more suited. She has developed a plan to implement these new international recommended methods in VQI and plans to further development and study the effectiveness of this assessment of renal dysfunction in her future work. Okay. Congratulations to all the winners. I think you'll agree with me, it's pretty spectacular, the work that they've done.
Here's some more information about the program, and thank you very much.